Hi students, good morning and welcome to this paper analysis session on FMGE. Welcome to this paper analysis session. Sorry. Here we will be discussing the dermatology questions and we will analyze the paper and look through it. Please remember, this is more of recall questions that we have. They may not be the actual questions, they may not be the actual images. We have tried our level best to give you the best possible closest question options and images, but I would require your help in case I'm wrong somewhere. So let's make this session fruitful. Also, don't start marking yourself. You've given your exams. I'm sure you've done well. And now is the time to relax. So let's just discuss this on a more lighter note. So I have few questions from dermatology here, and let's see if what I have is correct. And then you can obviously tell me if there is something I need to add up. So are you able to hear me and can you see me? Just give me a few thumbs up so that I know that you guys are able to see me. Now, the first question that I have is a female presents with multiple small pink unlicated papules on the face. What is the most likely diagnosis? So on the outset, I would like to say that the dermatology questions, if I analyze the paper, were quite simple and easy. Almost all the questions were from the very, very important topics which we have discussed in the last resort revision or in our webinars or in our lectures. And so I believe that you would have fared pretty well in dermatology, but you're free to give me your inputs on how did it go. So barring, I think, one questions or two, but most of them were totally from the very, very important topics. Great. So how was your paper, students? Since you're all online now, I would like to hear how was your paper? How was your dermatology part? So I'm sure you did well, and I'm sure you'll come back with flying colors. So this was a very, very easy question. You had been given in the question about unlicated papules on the face. In dermatology, we have discussed this numerous times that unlicated papules is seen in just one condition, which you have all answered correctly, molluscum contagiosum. So it's a viral infection which presents with unlicated papules on the face or other parts of the body. But we know that if there is unlicated and there is no other history, like there are certain conditions like cryptococcosis and other conditions where you might see unlicated papules, but then there is a vast history associated with it. There are other features associated with it, and on the top of it, none of them were there in the options. So options were quite simple: acne vulgaris, HPV, herpes. HPV we know causes what? None of them present with anything which is similar to this. Unlicated papules is molluscum, right? So I think this was the question. If there is anything that you would want to add up here, you can tell me. Yes, thank you very much. Yes, I also believe dermatology paper was very, very easy. Right. So I'll move on to the next question. Okay. Question about, yes. So Dr. Mariam, we've come to that question which you are mentioning. There was a question about a neonate who presented with the finding which has been shown in the image, and you were asked to diagnose it and give its treatment. Another question which we've discussed multiple times. So if you look at the image, I have a child, a neonate or an infant who is showing peeling of the skin on the trunk, on the groins, and also you can see a little bit of face and hands. And you have been asked to identify what it is and what treatment would you give. So if I look at the options, it's clearly a case of staphylococcal scalded skin syndrome. Now, if you remember, we have studied about SSS, which is seen in infants and neonates. There is usually a history of a focus of bacterial infection somewhere, from where the bacterial toxins, they go into the bloodstream, and this leads to toxin mediated rash on the skin. And the kind of rash that we see is peeling off the skin because this toxin targets my desmoglein 1. So it is the exfoliative toxin 1 which is targeting my desmoglein 1. Since we all know desmoglein 1 is present in the superficial layer of the epidermis, I see superficial peeling of the skin. So this is a toxin-mediated dermatosis caused by Staphylococcus, and this is referred to as staphylococcal scalded skin syndrome. The name is in itself very specific, caused by staphylococcus scalded skin because the skin is scalded off. And since it is a toxin mediated disorder caused by staphylococcus, you have to give antibiotics to this patient. Now, since it is an infant and neonate and we see significant peeling, the ideal choice of drugs are IV antibiotics. So we prefer IV antibiotics. So injections, Falexin, or any of these cephalosporins are my drug of choice. So again, a very straightforward question. So was there a mucosal involvement mentioned here? Thank you so much. I also believe that there were a lot of questions from LLR. So bulla can be mentioned. There can be bulla here. That's okay. There was no mention of peeling, just lesions, ma'am. So in the image which was given to you, was there bulla or was there peeling of skin? What did you see? No, okay. So if there is some confusion, I will just try to elaborate on rest of the options. Now, if you would have been given an image of hands, feet, basically friction prone areas, and you were given some bulla, then the chances of having epidermolysis bullosa simplex is a possibility. Epidermolysis bullosa is a genetic condition in which you see at the friction points formation of bulla or peeling of skin. Since it is a genodermatosis, you do not treat it. You have to just use precautions and bandaging. So in that case, my answer will become epidermolysis bullosa with bandaging. The rest of the two options, I think, were not important. If impetigo, if would have been given, there should be something on the face. You would have seen those bulla, you should have seen golden crust or something like that. And then again, you would have treated with antibiotics. So I think the only confusion would be in option A and B. That would depend upon what image was given and what was the history. Right. Great. Peeling nahi tha, lesion only. So if there was no peeling, you saw only bulla, which were there in friction prone area, and you marked epidermolysis bullosa with bandaging, then that is also correct. I got to know that we had a similar looking image. If it was the image, then staphylococcal scalded skin syndrome with injection cephalosporin. Clear? Now, moving on to the next question, which of the following best describes the characteristic lesion of Kaposi sarcoma? Now, again, if you go back to the LLR, I've told you in HIV, there are 2-3 things which are asked. One of them was Kaposi sarcoma, and they always ask you about the description of Kaposi sarcoma. Usually in the question, they give you the image. This time they asked you how Kaposi sarcoma looks like. Now, we know Kaposi sarcoma is a vascular tumor of endothelial cells. Since it is a vascular tumor, it would look like a raised red purple lesion. So there is no doubt here, you should just be knowing what is Kaposi sarcoma. And if you know it was a vascular tumor, you would have marked a raised purple red lesion. Obviously, if you look at the other options, small striated lesions that cannot be scraped off, they may be talking about leukoplakia or anything. But there is no confusion with the rest of the options here. So was this the question? So SSS present with mucosal involvement? Usually no. Mucosal involvement is usually not seen with SSS because the target antigen is desmoglein 1, but rarely the focus of infection may start there. Even epidermolysis bullosa, for that matter, does not present with mucosal involvement. So probably it was just given to confuse you. Oh, same. Okay, perfect. So I think this was the exact question as you were all telling me. Kaposi sarcoma seen with more commonly with HIV patients. So probably if HIV was mentioned in the question, that must have made it more easier. But you know that it is a raised purple red lesion. Clear? Moving on to the next question. Now, this I think was a little tricky one, but I'm sure you must have attempted it and done it right. Now, patient presents with fever after returning from a forest trip. On examination, a black eschar is seen on the back. What is the drug of choice for this condition? So there is a travel to forest with eschar formation on skin. So what is this condition that they're talking about? Absolutely right. This is scrub typhus. Scrub typhus is caused by Orientas or Chugumashi, you know that, and this is usually related to travel to forest. And because of the bite, it leads to fever, malaise, and typically on skin, you see these eschar-like lesion. Eschar is nothing but a necrotic crust like lesion which is present on an erythematous background. So this is scrub typhus, and treatment of choice for scrub typhus is doxycycline. In this image was not given. Okay, even if the image was not given, that's okay because they've mentioned in the question forest strip and eschar. If there was a DD of anthrax, do not get confused. Anthrax, you know, is a zoonotic infection. So if they had wanted you to answer anthrax, they would have given you some history of livestock handler or contact with some livestock, right? Here, typically, the forest strip is the giveaway point. Forest strip and black eschar related to scrub typhus. Scrub typhus is treated with doxycycline. Great. So even if the image was not there, this question was straightforward and I'm sure you all marked it right. So anything different in this question except for obviously you told me that the image was not there? Great. Moving on to the next question. A patient with borderline tuberculoid leprosy presents with the following findings. Which type of hypersensitivity reaction and nerve is enlarged? Now, this we've mentioned hundreds of times that there is only one nerve in leprosy which is better seen than felt. And a lot of times I've shown you the image of this nerve and told you that they ask you to identify this nerve. So when they are pointing towards a nerve like this, you know we are talking about greater auricular nerve. Now, even if we look at the options, it's quite clear that they're probably talking about greater auricular nerve. Now, coming to the hypersensitivity reaction, they've given you in the question that it was a patient of borderline tuberculoid leprosy. We know that borderline tuberculoid leprosy is prone to what kind of lepra reaction? BT leprosy, we usually see type 1 lepra reaction in which we see that the existing lesion becomes more red, more inflamed, and there may be nerve abscess which might be there. And this type 1 lepra reaction is a type of type 4 hypersensitivity reaction. So my answer here would be type 4 hypersensitivity reaction, and the nerve that is seen is greater auricular nerve. So anything different in this question? Because it might be a little different because we have a lot of information in this question. So if there was something which was confusing, difficult, please share here. So what I believe, if they've given you BT Hansen and then shown you greater auricular nerve, and probably there was also an image of the lesion which was red, inflamed, we know we are dealing with a type 1 lepra reaction, and we all know that type 1 lepra reaction is a type of type 4 hypersensitivity. Right? Clear? Exact question. Thank you so much. So again, a very straightforward question and a very, very important topic. Now, next question. A child was brought with complaint of multiple lesions. And when you saw multiple vesicular lesions on palm, soles, and oral mucosa, which is the most likely etiological agent of this disease. So what is this disease? This is so simple. The disease speaks on itself. So it is hand, foot, and mouth disease. So you have hand, foot, and mouth being affected. So dermatology, I always say, is a lot of names being there, but this is the most descriptive name anybody can keep because you have vesicles which are seen in hand, foot, and mouth. So this is called as hand, foot, and mouth disease. And what is the causative agent for hand, foot, and mouth disease? They asked directly about the lepra reaction, not hypersensitivity, and nerve was different in the other two options. So, as I said in the beginning of the lecture, this is what I've received from students like you. These are all recall questions. They may not be the exact questions, they may not be the exact options, and that is the purpose of conducting this paper analysis because we are analyzing these questions, we are getting your feedback, and we will come back with better questions, more precise questions at the end of these sessions. So please don't get disheartened. Please don't feel that you marked something wrong or something was not right. This may not, I have not I have not given the questions. So I do not know what the exact questions were. It is students like you who are telling me what the questions are. Okay, even if they asked only about the nerve, did they show this image of greater auricular nerve? Not given. Type 4, only 1 and 2 as different auricular nerve and anterior auricular nerve. So one thing is quite clear, that in the previous image, this one, they had given you this nerve. So greater auricular nerve was given, and probably they had asked you the type of Hansen, or they had asked you about the type of hypersensitivity reaction, right? Okay, no worries. So probably there were different options, but they asked you about greater auricular nerve. That's absolutely okay. We'll move on to the next question. So how about this question? Do you guys remember this question? Was that there? Okay. So I think there's some confusion with the leprosy question. Some of you are saying there were nerves were different. We will get back to you with the exact question. Thank you so much for your input. So probably there were different types of nerves which were given. But I think greater auricular nerve was there in the option, if I'm not wrong. Okay. So coming to the next question, we have hand, foot, and mouth disease. We had an image or the history of hand, foot, and mouth disease, and this is caused by Coxsackie 16 virus. So answer would be Coxsackie virus. Again, a very common viral infection that we've studied, and yes, it was there. So thankfully, this question was there. HFMD was there. And you all know HFMD is caused by Coxsackie virus. If we look at the other option, varicella zoster virus causes chickenpox, which affects the trunk. Human herpes 6 virus causes pityriasis rosea. Enterovirus can cause herpingina. So here HFMD is caused by Coxsackie A16 virus. And so that should be the correct answer. Okay. Okay, so moving on to the next question. So probably here again, I may not have the exact image. What was told to me was that there was some question in which a patient had been taking NSAIDs, and whenever he take NSAIDs, he develops a skin lesion at the same site again and again. So, on intake of a drug, you are developing a lesion which is happening at the same site. So, what is this? This is called as fixed drug eruption. Fixed because it occurs at the same site, and drug because usually it is after intake of a drug. NSAIDs, cotrimoxazole, and antibiotics, especially fluoroquinolones, are common causes of fixed drug eruption. So whenever the patient takes NSAID or the particular drug that he is prone to developing FDE, he will develop a circular erythematous rash at the same site again and again, right? So this is called as fixed drug eruption. It is again a type 4 hypersensitivity reaction, and it happens because my body mounts a reaction because of presence of memory T cells, right? So was this the question? Instead of first option, it was eruption occurs at same site. So yeah, that's what I say, that probably after taking NSAIDs, the lesion is occurring at the same site again and again, and probably you were given an armpit or somewhere where the reaction was seen. There was one option with recurrent drug reaction. So recurrent drug reaction is no term. So even if that was there in the option, you do not have to mark that. Fixed drug eruption is the term which is used for this kind of reaction. So if anything else was given, don't get confused. Fixed drug eruption would be the correct option. Oh, option A was not there. So you had fixed drug eruption was not there as an option. So what were the other options? So if fixed drug eruption was not there in the option, and if probably you had different options which I've mentioned here, and then recurrent drug reaction was given, then you had to mark that. But believe, recurrent drug reaction is usually not the commonly used term. Occurring at the same time was the option, same site drug reaction was there. Okay, so probably in the options, they had given you that the rash occurs at the same site. Instead of the question, they told you that NSAIDs he takes and he gets a rash and it occurs at the same site. So even if that was there in the option, probably they wanted to ask you how does it occur. So that would also be correct. Okay. So thank you so much, Dr. Mariam, for your input. You are saying that all these questions are correct, but the language was different. So you have to agree with me that it's very difficult to get the exact language because recalling that language is difficult for students. So I'm glad at least the questions and options were almost similar. Now, next question was, what is the most likely causative agent for a Zank smear showing multinucleate giant cell? Again, a very, very straightforward question if this was the exact question. So if you see MNGs or multinucleate cells on Zank smear, we have discussed it repeatedly. It happens in herpes simplex infection. So Zank smear we do for two main conditions, pemphigus and for herpes. In pemphigus, you see acantholytic cells, and multinucleate giant cells are a feature of herpes simplex infection, right? So if you look at the other option, varicella zoster, HPV, Coxsackie, they do not present with MNGs. MNGs are a feature of herpes simplex infection. Thank you so much. It's good to know that for some question, and at least you guys say that it was the same, right? So these are some of the questions that I have from dermatology. Any other question which you feel I've missed? Probably you remember the topic from which it was given. You're free to post in the chat box so that we can give you a better paper at the end of it. So, how I think this was a quite straightforward paper. As you guys told me, probably language was a little confusing, but the topics that they have chosen were good. They had covered only the important topics, and the questions were quite up to what we've discussed repeatedly. So I would want you to tell me if, in case I've missed any question in dermatology, anything related topic. So you are free to post it on the chat box. Otherwise, our next educator will be taking their session. Okay. So this was it for dermatology. All the best for your results, and I'm sure you all will do well.